All right. Well, it's 12 o'clock. I'm sure there will be more people who join in the next few minutes, but I think we'll go ahead and get started because we have a whole lot planned for today that is packed into an hour. We wanted to keep it to an hour to make sure that it was more doable for a greater amount of people, but we're going to try to be really efficient with our time today. So thanks so much for being here, everyone. I'm Shelley Facenti from Facenti Consulting, and I'll introduce myself more in just a moment. But I'd love for all of you to just start putting your introductions in the chat if you could. We'd love to just get your name, where you're from, and maybe if you want to say, whether you're already offering Matt or hoping to start or any of that, feel free to put that in the chat. Let me just go through and briefly, I have just a few minutes of opening slides to let you all know what we're doing today. So the first thing is we'll introduce the Facenti Consulting team and the folks from the Center at Sierra Health Foundation, and then I'll give a very quick project overview so you understand sort of why we're here, what we've done, and then quickly move it over to, we have four panelists today. We're so excited to have them joining us to speak. They'll each speak only for about 5 minutes, so very briefly on kind of a high-level overview of their MAT program and what that looks like. And then our hope is that by about 12:30, we're going to move into Q&A. And even though we've called this a webinar, we intentionally didn't create the meeting as a webinar. It's a large meeting format, which means you are on video, you're able to unmute if you turn on your videos, you're able to unmute yourselves, although we'd really prefer you stay muted unless you're actively asking a question. But we wanted to have a whole half hour today of time for you all to be able to ask questions of our panelists about, what they did, how it worked. Ask them things that will help you all replicate pieces of their program that make sense for you in your setting. So that's our main goal for today, is to have that time for Q&A. You can put things in the chat and we'll keep an eye on those for Q&A, or you'll be able to unmute yourself and ask directly during that section. Okay, so I'm going to roll right along with that in mind. So I'm Shelley Facenti here on the left of your screen. I'm the principal at Facenti Consulting, which is the health equity focused consulting firm based in California that has worked with the Center at Sierra Health Foundation on a much bigger project around kind of overall sense of the landscape and opportunities for strengthening the systems of providing medications for addiction treatment for people, primarily people who use opioids, though not exclusively, throughout California. And I'm joined here by Savannah O'Neill. Savannah will be facilitating part of the meeting here when the presenters are going and helping out today. Savannah, I don't know if you wanted to at least say hi.
Hi, everyone. Nice to be here and see you all. And yeah, like Shelley said, I will be getting to work with our lovely panelists to share about their work.
Great. Okay. And then we're also, this project was commissioned and overseen by the Center at Sierra Health Foundation. And I know we've got folks from that team here today. And I think uh, momentarily, I think Madeline is going to talk briefly about just sort of their perspective about doing this. But I wanted you to see the whole team, all of whom I think are here now. And we've really appreciated working with them throughout this. Madeline, is it you who's going to say a few words? Do you want to just say some opening thoughts about why this project? Why now?
Yeah, thank you, Shelley. And thank you all for joining us. I love seeing all the names and organizations in the comments, lots of familiar faces, or names, I should say. So excited to share what this work has accumulated in with you all, and really with the center, we are often asked for recommendations around funding. We're also, We look to the best practices in the field, and we want to make informed decisions. And so we really asked Vicente to help us understand the landscape around MAT in California. We know that there's been a lot of changes over the years, and things have shifted. Things change day by day, as I'm sure you all experience. And so we wanted to have a good sense of what that landscape was, what are the best practices we're seeing, where are recommendations floating up from those who are on the ground and doing the work and receiving services and connected deeply to this work. And so that was kind of the impetus for this project. And we're really excited to hear from our partners today on some of their best practices and strategies. So thank you for joining us, and I will turn it back over to you, Shelley.
Thank you so much. Okay, so we really started with this premise, like we know that MAT works. We didn't need to collect a whole bunch of data to demonstrate that it works because so many people have been doing that over time. We did do a literature review to summarize all of that and package it up. But we started with that understanding. But we also know that there are Californians who struggle to access MAT even when they want it. And so we really wanted to explore that through this project. This is just one example of the types of things we did in a much longer, more detailed landscape analysis, which you'll if you really want to dive deep and read a long report around this, it's available and we'll give you the link and you can look at it. But you can see from here, the shading on this map, the darker the shade, the more fatal overdoses there are, the higher the fatal overdose rate per 100,000 people in that area. And yet, the bigger the black circles, the more providers there are to provide MAT. So in some cases, those are well aligned. You have these big circles in counties with a dark red color. That means there's a high fatal overdose rate, but there's also a lot of MAT providers there. But you definitely have some places where the colors are fairly dark and the circles are small, which means there's a high rate of overdose and there's not a lot of MAT availability. So that's one of the things we were looking at and trying to understand better. Why is that? What can we do to try to shift that inequity? So there's a website that now exists that we're kind of officially launching. I know that's funny. It says June 18th, 2025, which is when we created the first skeletal draft of it, but obviously we need to update it. Today is kind of its official launch into the world. I think Savannah, if she hasn't already, because I'm screen sharing, I can't easily see, is going to put the link to this in the chat. And this is a website that's intended to showcase all the pieces of this project. This is just a screenshot, but the actual website, there's some beautiful scrolling photos, and you can click on all these different things, see different maps, see different data. But you can also download a lengthy and detailed landscape analysis report that has all sorts of information about what we found we did surveys, we did interviews, we did focus groups, we did a literature review, we did direct analysis of a bunch of data, did some of the mapping you saw on the prior screen. So this has been a very comprehensive effort to understand what the status is and where are the places that we can make some improvements. And all of that is hosted on this website. But one of the things that's also on this website are a whole bunch of videos linked to these places throughout the state of California. And so when you scroll down to this case studies area, you can actually click on the different circles or scroll through and see a little description of what it is, and then click on the link to a YouTube video. And this is the format we use to create case studies of 10 programs throughout California that all have very different settings, very different approach, to providing MAT, and we wanted to understand, what's it like there? What's working there? How and why do they do it the way that they do it? And so we went there, we did site visits, we brought a filmmaker, and we did interviews and collected footage and created these amazing videos in partnership with these programs. And there are 10 amazing videos on that website. Only 4 people are featured here because we only had an hour, but 4 of the folks who were leaders in the programs, in 4 of the 10 programs here, are our panelists today. Each of these videos is only about 5 minutes, and so we knew that you can only get so much in 5 minutes. We think the videos do a great job of conveying the programs and what happens, but it's just a snapshot. And so we really encourage you to go to that website, watch all of these videos. Again, they're only about 5 minutes each, and there's just so much to learn and see and celebrate in these. And we wanted to give you all an opportunity to kind of bring these to life in a way and have the folks from 4 of these programs give you a bit more detail and then be here to answer your questions. So that is our plan for today. So now let's hear from some of those who've done it. I'll hand it over to Savannah to introduce and pass off to our panelists.
Thanks, Shelley. Yeah, I'm so excited to have the panelists we have here who've been doing this work for a long time in California. So I will start with Hillary Katzen, who is the practice manager of the Alameda Health Systems Bridge Clinic at Highland Hospital here in Oakland, where I live. Hillary, you want to go ahead?
Sure, yeah. Hi, everybody. I'm Hillary Katzen. I'm actually the service line director for substance use disorder treatment at Alameda Health System, which is our county adjacent health system that includes 3 acute care hospitals, 1 psychiatric hospital, and then a series of ambulatory outpatient clinics. Part of my job so I'm the director of services across the system, and then I am also the practice manager for the Bridge Clinic, which is at our biggest location, our Highland Hospital. So we are an outpatient drop-in ambulatory clinic, so we operate the same as any other specialty clinic does in our system, like cardiology, podiatry, whatever, all the regular ones. We are located at Highland Hospital, which is near downtown Oakland, and we offer same-day in-person and telemedicine visits. So we have anywhere from 120 to 150 patients on the schedule per day, and I'll get to it later, I think, but about 2/3 of those are telemedicine visits, and we've had up to 50 drop-in, walk-in patients per day. And just for some sense of scale, so we are the big Trauma 2 or Trauma 1 center in our county. So we have a big ER. There are days when we have more people walk into the Bridge Clinic than walk into our ER. So just for a sense of scale, we're doing an awful lot here. So we are an MAT clinic. Our bread and butter is buprenorphine, but we will treat any substance use disorder. And we have a real harm reduction lens. So we are very fortunate to be partnered with a community organization called HEPAC, which is a harm reduction organization that's been around Oakland and Alameda County for 30 years now. And so we have some of their staff who are on site with us to do harm reduction counseling and to offer harm reduction supplies and manage our naloxone program, et cetera, et cetera. So we do quite a lot of harm reduction. And then all of our providers do harm reduction counseling as part of the medical visit. We have about 35,000 visits in the last year, and about 60% of them are telephone visits. And most of our patients are on Medi-Cal. I think about 80% of our patients are on Medi-Cal or Medicare. Most of them are either unhoused or not stably housed. And a large proportion, I can't remember off the top of my head, but the biggest proportion of our patients are opioid users, followed by alcohol users and stimulant users. So I think I covered everything on here. I guess we also do quite a bit of other medical treatment too. So we do MAT, but we also offer HCV and HIV and other STI treatment, testing and treatment. We do reproductive health, and we try to be available for all of the kind of health issues that go along with substance use, because we know it doesn't exist on its own. So this is just part of our cute little team outside of Highland Hospital. So we are comprised of physicians, nurse practitioners, PAs, and then we have 2 social workers on staff who do kind of short-term therapy and behavioral intervention. We have 2 community health outreach workers who do case management, kind of light case management, but mostly community linkage. And then we have a bunch of substance use navigators who are both visiting patients bedside in the hospital and seeing patients in the clinic and answering our telephone line, which is 40 hours a week. And I should have put some more details about that in the slideshow, but I'll talk more about it. So the key things to know are that this isn't written up here, but I'm going to put it in the chat after we're done. We have a 40-hour-a-week telephone access line that is run by substance use navigators. So anybody from the community can call or text and get a hold of a substance use navigator with whatever they need at any time during the week. So if that means you need help troubleshooting with your pharmacy because you can't pick up your buprenorphine for whatever reason, our sons will help with that. If it means you're in some kind of a crisis and you don't know what to do, our sons will help with that, including if you're in withdrawal, our sons can hand off the phone to a doctor right there so that you don't have to wait, you don't have to get a call back. You can just get on the phone with the doctor and figure out what your next step is going to be right from there. So that's really the most important part of our program, and I guess my brain is really in a fog because I did not include that in the key things to know, but that is the key thing to know. And I'll put our phone number and everything in the chat. But another really important piece of our program is that we are co-located with a DMC ODS SUD treatment program. So we have just right across the hall our more traditional behavioral health outpatient program where patients can come and get counseling and therapy and groups and all that. We also have a consult service where we have sons and providers who will go visit patients bedside in the emergency department and in the hospital. And we know from the data we've collected from that service that patients are like 4 or 5 times more likely to follow up in the clinic if they've been touched by a provider while they're, or a son, including sons, while they're in the hospital. So that's a really important part of our work. And then we also do, as I mentioned, HCV, HIV treatment, reproductive health, psychiatry. We try to we assume that most of our patients have SUD and mental illness, and so we really try to do as much as we can to treat the whole person. And I think that's it. So I'll stop there and we can come back.
Thanks so much, Hillary. Yeah, there's always so much to share about these programs, and so I really appreciate you giving that overview. And just to note, we're going to do all 4 presenters, and so if you have questions that came up in that one or as we go, just hold on to them and we'll talk about them in the next 10 minutes after we get to hear from more folks. So Arlene Brown is next, who is the founder and CEO of Crossroads Recovery Center. And Arlene, you can jump on now. It's so good to see you. You're muted, but you're still muted, Arlene.
Thank you. I couldn't hear you because I was talking, Savannah.
There we go. Hello.
I was saying Manahoot Nanini, Arlene Brown. I'm a member of the Bishop Paiute Tribe in Bishop, California. We're located in Inyo County. I'm grateful to be here and part of this larger work happening across California. Our county actually, we're considered rural, we're considered frontier. We have 5 tribes throughout our valley. Tribal communities, that is, and then our population is really under 20,000 for our entire county. We're nestled in a beautiful valley underneath the Sierra Nevadas, so we are, pretty geographically isolated. Let's see, what else can I tell you? We don't have a homeless shelter in our area. We don't have detox centers. We don't have inpatient programs here, and so a lot of this work has been done to meet the need that is demanded by our community and just a response to what's happening, and really a creation with the foundation in mind of like no barriers and something that's ours. So like decolonizing a lot of these services. And I think one of the biggest things that um, for us is that our culture comes first and that we put that inside of everything that we do here in our program. And so we're a little unique in that sense. There's no methadone in our county, so there's no methadone prescriber. A lot of the clinics, they utilize buprenorphine. The closest methadone clinic is about 2.5 hours away from us. And so that's not really fitting for any of the patients here and options. And it's actually like a really big deal too, because we have Mammoth Mountain right next door to us. And a lot of people who are traveling or on vacation have a lot of work to do. So some of the calls that come into the emergency department or the clinics is actually around like, how can I get a dose because I ran out, my vacation's longer, what have you. So next slide, please. So one of our core beliefs is that our culture comes first and we put evidence-based practices inside of that and what makes sense for us. And that's kind of how we designed and created all of our programs and our services. Next slide. With saying that too, that means that we have added our language, we've added ceremonies, we've added traditional medicines, traditional foods. As part of that, this is a welcome sign that you see when you come into into our place. And we want to just be able to invite those conversations. We're a syringe exchange program. We have a recovery residence program. We have a lot of different services. Next slide. And a lot of the success has really come from working with our tribal communities and our people and letting them know where we're coming from as well and helping, like in the beginning, they said MAT, we know it already works, and it's building a pathway for our tribal communities and MAT because we know it works. Next slide. The Western model, like a lot of other services, were really created with us in mind. And so it doesn't really encompass our healing. And so we've really worked to try to change what that looks like. Next slide. So we know already the retention is having that trust. We know that cultural identity is a protective factor. Low barrier access is so crucial in community involvement towards that healing and having our staff, everyone here has lived experience. Next slide. But there is differences in Indigenous MOUD, and that's because we, integrate all of our cultural items. We integrate family support. We integrate the greater community, acknowledging traumas and different things that happen. So it's not just like a clinical visit. Next slide. I just wanted to share with you our snag bags. We are harm reduction. Next slide. This is just an example of some of our language and ceremonies that we have within our clinic. Next slide. And the biggest thing that I would like to share with you guys is really how we understand MAT and medication and how we're actually describing this with patients of why it's so important and how we're destigmatizing it as it's not just swapping medications, that it is actually something that's more traditional because there's a lot of stigma around it, misunderstanding and information. Next slide. So that medicine while teaching is one way that we're able to understand that MOUD actually works and has some really great benefits. And we don't just say, hey, it's just a medication that's going to help, prevent overdose. It's just the one that's going to help with withdrawal. It's just, we describe it more as what the mental benefits are, what the physical benefits are. Next slide. What the spiritual benefits are. We break it all down into those areas, and that's how we describe the medication and why we're using it. And that's how we actually help people stay on the medication so they know the importance of it. And that's how we explain it to our tribal communities. Next slide. And this is just more examples of what the emotional piece, physical. And then I just wanted to share that we do have a native harm reduction toolkit that's out there, and that has a breakdown of the things that I just talked about with other examples in there as well. So thank you.
Thank you, Arlene, for getting so much information in your short minutes. And again, folks will have the chance to ask Arlene about the programs that she runs. So thank you so much. And now I'm going to pass it to Dr. Sinai Kanani, who is the Medical Director of Emergency Medical Services at Contra Costa Health. And yeah. Dr. Kadani, are you here?
I'm here.
Hello, nice to see you.
Likewise. Thank you. Appreciate that introduction, Savannah. Like she said, I'm the medical director here in Contra Costa County. We can advance to the next slide. So our county is located here in the Bay Area. It's in the East Bay. We have a population of approximately 1.3 million with 130,000 calls for service annually and about 85,000 EMS 911 responses annually. We employ over 1,000 paramedics and EMTs in our system. And in 2023, we had 178 opioid-related OD deaths in our county. So in that slide that Shelley showed earlier, we were one of those kind of light salmon pink 16 per 100,000 deaths. Still an opportunity to intervene. We were the second jurisdiction and county in the whole country of the United States to offer buprenorphine in the field. So our belief is if clients and patients are having trouble accessing the medication, we should bring it directly to them. You can advance to the next slide. And the primary reason is, and recent studies are showing that approximately 75% of individuals that die from an opioid-related death have been seen in a local emergency department for opioid use disorder within the preceding 12 months prior to their death. So we know that we interface and engage with people that are at highest risk for opioid-related deaths. So it creates a powerful opportunity to intervene at the moment of crisis and to introduce them to a really powerful medication. So I was actually one of those that was a naysayer. The program that we have here in our county was adopted by my predecessors, and I'm really grateful that they had the vision and foresight to do so. I mean, it's not going to save a life immediately, but buprenorphine, again, you can introduce somebody to the medication at a time where they're probably most motivated to make a change in their life. And if nothing else, you get to relieve suffering. For a lot of us emergency providers that have treated people in the throes of withdrawal in the past, short of giving them another opioid, we were relegated to treating their symptoms with antiemetics, nausea medications, and the like, and often unsuccessfully. And if you don't treat it within a certain window, the impetus for one of those clients is to leave and probably use again. And that use can potentially be the next kind of deadly overdose. Next slide. So what does it take to introduce buprenorphine in the field or in a 911 system? One, funding. And funding streams are ample currently to be able to do this. California EMS Bridge and the Public Health Institute are offering grants to LEMSAs in the state of California that want to offer buprenorphine in the field. You'll apply to the state to add the medication for local optional scope use. You'll administer trainings. You'll identify champions. And this is particularly important because you want to counteract some of the stigma that our own providers have in treating this disease entity with, again, MAT. And then you'll want quality assurance. What we noticed is our buprenorphine use in the field tends to wax and wane. So you constantly need champions, people auditing charts, looking for missed opportunities and giving that feedback directly back to crews in real time. So it stays at the forefront of their mind, and you can continue to see utilization rates at high rates. Next slide. The OMRI stands for the Opioid Multi-Agency Response Initiative. It's kind of the 4 pillars of our program. One of them just happens to be the ability to give buprenorphine in the field. The second is that we want to identify and really what's the secret, the secret magic sauce to our program is we identify as many clients and patients with opiate use disorder as possible. So we flag the patient care report and we look for certain keyword triggers that alert us that this might be a patient with opiate use disorder. And the charts that flag for those key terms gets sent to our public health department and the substance use navigator at our county hospital, who identifies, looks at the chart and says, yes, this is potentially a client, and then reaches out for follow-up and tries to get the patient plugged into rehabilitative services more long-term. And what we've noticed is about 30% of patients that have received buprenorphine in the field not only accept long-term rehab services, but stay in it a month out from their encounter with us. The next pillar is that we give naloxone liberally to anybody potentially with opiate use disorder, their families, their friends, their loved ones, which might be really helpful in the case of a future overdose. And then we try to transport individuals as much as possible to our county hospital. And the reason being is they were one of the earliest adopters of a son at their hospital. And there was buy-in from the emergency physicians there to administer buprenorphine in their emergency departments and then send these clients out with short-term prescriptions until they can be, again, plugged into more long-term services. Most of our hospitals in the county now have followed suit. So there's less of a need to transport directly to that hospital. Most of our hospitals now have Sun and are pretty dialed. Next slide. This is our protocol for anybody that is interested. There's a whole set of clinical criteria that are used to determine whether somebody is in opioid withdrawal, and that can include a patient that's been reversed in the field for their overdose with naloxone and is now in withdrawal. So there's an opportunity to administer the medication there. The paramedics calculate a CAL score, and if they meet the threshold score, they would administer the medication. The initial dose is 16 milligrams, followed by an 8 milligram dose 10 minutes later if they still meet the clinical threshold. We have some exclusion criteria, which are indicated in the protocol. Next slide. And that's about it. I would say my takeaway is if you are a pre-hospital system considering administering buprenorphine, please do it. It can change the trajectory of an individual's life, even if you don't think it may save them in the acute phase. The introduction of the medication in our setting, again, for some of the highest risk individuals, can be life-altering.
Thank you so much. Yeah, and in the video about their program, there's great resources for any EMS or folks who are close to EMS work who are not doing this yet in your county. Thank you so much. So, our last presenter before we get into questions and answers is Ava Yekul from Lakata. And yeah, really excited to hear about all the different settings. So I will pass it over to you, Ava.
Thank you so much. Such an honor to be here, and my goal will be just to share some our journey in implementing MAT services, incidental medical services, and residential treatment facilities, and how we have pair and utilize recovery bridge housing as addressing social determinants of health. So I have the pleasure to serve as the project director for MAT services with Los Angeles Centers for Alcohol and Drug Abuse. And thanks to this funding opportunity with the Sierra Health Foundation, we were able to certify and have fully functional 2 residential treatment facilities. We have over 105 beds providing residential treatment beds and with MAT services on site. We are working at this time on licensing 2 other facilities that are going to be dedicated for LGBTQ and plus and pregnant and postpartum women that's called PPW. So those are our specific facilities that we're working right now on getting the certification and making it operational for MAT services. Something unique about our population is that over 85% of our patients, they are justice impacted. We make a strong efforts to fully re-entry these individuals to their community. And to do so, we pay close attention to social determinants of health and how this has been impacting them for not some years, but maybe decades. And something that has worked for us and that we feel pride of it is that we have recovery bridge housing where people that when they finish residential treatment, taking a step down to an outpatient facility and leaving our recovery bridge housing. And as long as they are receiving outpatient facilities, they can live in recovery bridge housing. We realize that it doesn't matter how much we invest in treatment, if we don't prioritize addressing these determinants of health that's still affecting them, long-term recovery will be compromised if those factors are not addressed. Something else about us is that we prioritize harm reduction as well. We do a lot of efforts in low barrier access to MAT services and to resources to harm reduction. I know that I don't have so much time, but these are our facilities over here. We have over 141 treatment beds, and this is not updated. I know that we have over 400 recovery bridge housing beds at this time. So by last time, we have updated the locations. Next, please, because I know that I don't have time. I want to show you how our locations looks like. And the reason that I'm showing you how our medical sites looks like is because we make efforts on create a positive experience for our patients. We know that many of them, they have been stigmatized or have awful experience with the healthcare system, and that we are aware that this might be the first time that they have contact with a physician that is there available to prescribe MAT services on site. So we make sure that it looks the best standard of care that we can. Next, thank you. And some key takes away that I would like to share with you is that we realize that a strategic recruitment is key, making sure that if you're an administrator trying to implement IMS at residential treatment facilities, you know what will be the expectation of these prescribers that you're onboarding when they come on site, that you're aware of what electronic health records they will utilize, e-prescribing, and if you have your CMO with you, your chief medical officer, that you work that before recruiting more prescribers, and that if you're going to offer telehealth services, there is a lot of heavy lifting in managing vendors and making sure that everything is fully operational on site. There is something happening in the background that as administrators, we can make it easier for the prescribers. And if we identify any barrier that is causing difficulties for the patient and the prescribers, we can lift it and make it easier for them. Knowing the billing codes, why am I saying this? Because at some point, these grants, you will need to question how we're gonna make this sustainable. So that is important. Also, some difficulties that I have heard from other organizations and even for us is the outreach of the prescribers. How do I hire them, right? Like, should I just post it in Indeed, or how do I do this proactive hiring? And what we have done, and it has worked for us, is that we have reached out to addiction medicine fellowships to UCLA, Loma Linda, USC, and that's the way that we have hired addiction specialists for our organization. Something that I would recommend is participating to conferences, and I'm gonna promote this one that I'm not getting nothing in exchange, but I love it. As an administrator and someone that is overseeing operations or helping to improve operations, I highly recommend this conference because they are not doing the same scope than drug medical programs, but they do health services. So they are already experts in how to deliver the best medical model for their patients. So you can learn from that, integrate it to your scope of practice. Something that I would recommend is paying attention to not just the prescriber, but also to the medical staff that is working with them. And that's why I'm putting this beautiful picture over here. Investing on them and making sure that there is a cohesive workflow for them to support the prescriber. We are providing MAT services in a residential treatment facility where 50 minutes with the prescriber or an hour might not be enough for the patient to fully consider MAT services. So something that has worked for us is utilizing these medical staff that are every day with them, um, doing the medication pass and having close communication with their needs so they trust them. And when they communicate education and MAT services, they are already informed and well educated when they meet with the prescriber. We provide everything that is FDA approved and off label for stimulant use disorders. The only medication that we do not prescribe because we don't have license for that is methadone. Anything else, we offer it for whatever works best for the patients with the guidance of our physicians. And I think that that's it on my end. I don't want to take more time.
Thank you so much, and thank you all for sharing so much and being thoughtful about time. We really appreciate it. And before I pass it back to Shelley to facilitate questions and answers, it's just incredible to hear about so many different programs and really the vast difference in access as from 10 years ago. So it's exciting to hear about all this and hope you all can get some insights into more you can do. And I'll pass it back to Shelley to facilitate the Q&A.
Great. Thank you so much. And yes, I do just want to lift up. I know there are other people on this call who have helped us in site visits and showed their amazing models and are featured in videos. And there are other people on this call who have amazing programs who we weren't able to feature in videos. Certainly, the four that we were able to get as panelists here is no comment on the quality of those above so many others in California. We really were looking for a cross section, and we're so grateful for those of you who did present, to be willing to not just present. Only 5 minutes is actually quite difficult to present so quickly, but also to make yourselves available for questions. So with that in mind, I'm going to try to pin our four panelists and unpin Savannah. And let's see, Ava. Okay. So we've got the four of you here, and we really just want to open it up to, I can ask some questions, but I've already talked to these lovely folks quite a lot. And so I'm sure that others of you on this call have questions. I'd love to encourage people to unmute yourself and ask or put something in the chat, and I'm happy to ask on your behalf if that's easier.
Well, I'd like to go because I can see we're running out of time. So, and I'm actually probably not going to ask my question now because there's no way you can get it answered in just 15 minutes. But Eva, I remember you from another meeting that I was in, and you were great then. And since you have the same kind of program as we have, which is residential, could you just share your contact? You shared it with me before, and I've been meaning to reach out to you, and I lost it. So actually, I just want your contact. Could you put it in the chat? And then I'll just I'll contact you directly, and you can provide me feedback, because I want more feedback on your medical staff makeup and how they interact with the different phases of bringing in people from MAT, from the beginning through oversight, intake, assessment, intake, and then the oversight, and how that works, because we're struggling a little bit with the medical piece of our MAT services. We do well when we get them from detox into MAT, but when we bring them in on MAT, we struggle with just the medical piece. So if you could do that, I appreciate it.
Thank you. I just shared my contact, and that reminds me that we did a recent walkthrough with other organizations that they were fantastic. They came over to one of our residentials and we showed them around. They met our program manager that is on site in that specific residential treatment facility. And we are open to that as well. Just put it on the table.
Thank you.
Thank you so much. Jennifer, Ali, I see your hand up.
Yes, good morning or good afternoon. It was a great presentation, so much helpful information. It's exciting to see the growth in access throughout the state. I was wondering for the emergency department providers, what type of referral process do you have for long-term recovery in place for your patients?
Is that, well, I wasn't sure if that was a question for me.
for you, or I think it was maybe Hillary that did the first presentation with the Bridge program. I'm just curious to know what you do for referral for long-term treatment.
Well, I can speak to that, not necessarily directly out of the emergency department, but we do have, well, I'll start with the emergency department. So we have a team of substance use navigators who rotate through the emergency department. So they will be dedicated to that space for a day. We also have weekend coverage, and so they'll go bedside, they'll go find patients and help connect them to whatever services they need connection to while they're up there. Most of the time, what we try to do is pull them into our outpatient clinic where we have a lot more resources. And we have 2 community health outreach workers whose full day is dedicated to getting patients connected to longer term treatment and other kind of longer term services outside of the community.
I would say our experience is similar, or most of our hospitals have substance use navigators. So our goal is to, again, flag a patient that's coming to their hospital as quickly as possible. So a lot of times, a patient with OUD or somebody who's received buprenorphine in the field from us will be flagged for one of the substance use navigators. So if it's during business or daytime hours, they often will meet the client directly in the emergency department and will begin an intervention there. If it's after hours or on weekends, they will attempt to make contact by telephone. So we educate our crews on getting good demographic information, and particularly a good working number where we might be able to contact the patient.
Thank you so much. I know I see Ryan Johnson's hand, but first I want to just go to a question in the chat and then we'll go to you, Ryan. The question in the chat for everyone is, how do you handle participants, or maybe it's especially for you, Ava, because it says residential setting. How do you handle participants that want to stop MAT against the recommendation of the program?
Oh, that's a good question. And I think that we have that very often. I believe that first we need to make sure that our culture and our system is not imposing any barrier on the patients as well. So education with our staff and proper training, I believe that's key. So we make sure that we all are speaking the same language or going to the same goal. We know that our patients might be struggling with health literacy as well, and that it will require not just one time, but an ongoing education so they can have take better decisions and have better health outcomes. But at the end, that will be between the physician and the patient, right? Like we respect patients' autonomy, and what we are doing is empowering them to take decisions and take medications that work for them, not for the program. So I would say that a lot of education and efforts from the medical staff to educate the patient for the benefits of taking MAT services.
Thanks so much. Okay, I think there's 2 names. Oh, maybe there's 2 people. But go ahead, Ryan Johnson.
Yeah, there's 2 people, but I'm the one asked. My name's Ryan. I'm asking the question. I'm a program manager at Sacramento Recovery House. So my first question, I think, is to you, Shelly, I think, or maybe it was Hillary. It was the first slides, and it was about stimulus use disorder. Are you guys currently doing anything in residential for stimulant use disorder in MAT? And I'm just curious about that because we haven't really gone that route yet. And then I'll ask my second question after that's answered.
Great. I think this might actually be a question better for Ava, who's because LA CADA is doing some of this stimulant work. I will just say for my part, as someone who kind of went all throughout California and talked to a lot of different programs, most are focused on opioid use disorder, but there were a few that are trying to use medications that are available to address the concerns of people with stimulant use. And Ava's program is one of those. So I'll pass it off to you.
I'm sorry, the question was if we utilize a stimulant treatment for stimulant use disorders?
Yeah, yeah. What mat are you using for mat?
Oh,
Kind of medication are you using for?
and and we have a physician on the call as well. But our physicians, they utilize off-label medication for a stimulant. So they utilize Vivitrol paired with
Mhm.
Wellbutrin.
Okay.
And our CMO, our chief medical officer, and he's an addiction specialist, and he's awesome in improving treatment and MAT services across our agency. So he supports the use of off-label medication for stimulant use disorders. So,
And then maybe this second question is also for you, Eva. So one of the things that we struggle with a lot is clients being on very high doses of their meds and then, struggling to stay awake in groups and, more coherent. And we partner with an agency out here that has supplies our mat and they're great, but it gets very hard because a lot of times clients don't want to split their dose or don't want to, go lower on it because they like the way they feel, and obviously we aren't doctors. We can't make them do anything, but at our program also, they have to be able to participate and, be a part of. So that's something that we definitely struggle with. And I was wondering if you guys have the same struggle, if, what your counselors will, do to help with that, with the doctors or whatever. If there's any other helpful ideas you have, maybe that we aren't doing.
yeah, and thank you for that because we make efforts in making sure that we have a multidisciplinary meeting, that we also the physicians are not working on silo by themselves just with the patients, but they are also listening to the clinicians, to the input of the counselors, or what the medical staff is saying about medication compliance or how the patient is presenting to them. They might have a more limited time with the patients than someone that is working 24/7 and all the time with the patients, right? So they might have a very heavy input from their treatment. Something else that our physicians, and we have experienced this before, is that the staff on site, they panic when they see someone that is being sedated by the medication, and they always attribute it to the MAT services. But I will also offer this as a question for your program. Is the patient taking antipsychotic medications as well? Because that can cause sedation as
Of
well.
course,
So just
yeah,
address always the whole picture and not
yes.
just attribute it to the MAT services. But yeah, I would say promoting these multidisciplinary meetings that in our end has worked. Like we have medical meetings and also with other counselors, clinicians, and other credentials.
Yeah, it's very similar. Same, very similar things that we do. Okay, thank you so
Mhm.
much.
Excellent. I think I got all the questions in the chat. Does anyone else have a question you'd like to either add to the chat or just unmute yourself? This is such a good opportunity to ask questions of people who've really been very successful at doing this in very different settings. So I encourage you to go for
Hi,
it.
I'm Damien Benavides. I'm from Progress House. We have residential treatment facilities and we have implemented MAT in-house as well. So my question is regarding billing. I haven't even really dug into it yet, but I know I want the sustainable after the grant, right? And I just wanted to know if you've had any success with at least billing for like our nurse practitioner who does all of our prescribing, and she meets actually remotely with our MAT clients. And is this something that I don't know if you guys are familiar with SmartCare, but we use SmartCare for some of our funding counties, and if it's the direct billing code that we can use for our nurse practitioner for her services.
That's for me.
Yeah, probably.
Oh, yes, and that's why I said it since the beginning. Like you're right, sustainability is a big thing. You don't wanna not be able to provide services after 2 or 3 years to these patients, and um we have billing codes, and we are very grateful with LA County. I don't know if you're in LA County, but I know that the billing codes for MAT services are specific to each county. So we can have a specific reimbursement for MDs, MPs, and even LVNs, MAs, and RNs. That's the reason that we have a multidisciplinary team in the medical team as well, because those positions are sustainable. And something that we did is that we didn't wait for the physicians are direct patient care. Like they are used to very good EHRs and hospital level. So if we want to grab those physicians and bring them here with more limited resources, we will fail. So we had to do a lot of administrative work to make sure that we have the right billing codes and the right guidance for them to feel comfortable with, okay, I have to build this code, and this is the type of requirements that Medical will be looking up for. So we did that with QA in our billing team. We sit down together, we review all the medical codes, and instead of just giving the physician, oh, here's the billing matrix that is public in LA County, you can just grab it from their website, and we did it that is public, because we don't want to incentivize what is higher billing or lower billing. We want the best for the patient. So it doesn't matter, but we stream it for them. Like we did the work for them.
Okay.
Yeah.
Okay. And you work with Drug Medi-Cal as well, right?
Mm-hmm.
And so I don't know if your facilities have like a daily rate that whoever your funders are, daily rate that they give you for residential treatment, right? And so this is something that we can bill directly outside of the daily rate, right?
Correct. Yes. And it's a significant amount that will benefit the overall sustainability of your program. And it is different from MDs to MPs to RNs to LVNs, different rates, but all of them are on top of the day rate.
Okay.
Thanks God. Yeah. We're grateful for that.
Okay. Thank you.
Thank you both. There was one question in the chat from James that was, can you share how peer support specialists are used in the process? And I see Hillary shared some about SUDS in the chat, but do any other panelists want to share some other commentary on how you use peer specialists? No.
I can share something. I don't hold any expertise right now, and probably another colleague might be more qualified to speak about the peer supports. But what our organization was working on making sure that all the monitors, we were having monitors in residential treatment facilities. Instead of having monitors, we were having peer support specialists. And we have our own academy in Elicata. So we offer free training to our staff and making sure that they can be part of that credential. They have billing codes as well on top of the day rate. So that's something for your facility to consider how to better utilize them, to also offer sustainability to those positions. But they are awesome in advocating and empowering, following up with the patients. I recently integrated a peer support to the MAT team, and what he's doing is supporting the appointments, making sure that there are no shows for the appointments, that he's rescheduling, that he's motivating them to come over. And what better than someone that can understand what you're going through?
Yeah, if no one else is going to jump in, I just want to reiterate what Ava just said. When we went throughout talking to people throughout the state, we did a lot of focus groups with clients, or some of the focus groups are actually with people with opioid use disorder who weren't seeking MAT services as well. And one of the things we heard over and over is how much it matters to be able to talk to someone who's experienced what they've experienced, whether that's specifically with opioids or just in general with housing, with all the other challenges of life, that having a peer who feels similar makes a huge difference. And so wherever those things can be people can be integrated in as peers to help make connections to the program, we pretty much universally heard that was a positive asset. And I think, our panelists would likely agree where that makes sense from what we've heard before. So, well, thank you so much. It's already 1:00. I can't believe how fast the time went. I do want to share both my and Savannah's email in the chat in lieu of sharing our panelists if they haven't already shared their contact info, so that if you have more questions, you can reach out to either of us, and we're happy to answer those questions or pass you along to the folks who can. And again, to give you one more time, that Story Maps website, which is where all these videos are and so much other information, which hopefully, oh good, Savannah just put in there again. So thank you again so much to our panelists. We really appreciate you taking the time to share your expertise, and to all of you doing this important work. We know it's not always easy, and it's often not easy, and we really appreciate the community continuing to work on these issues. Thank you so much, everyone. Have a good
Thank you
rest.
for having me.
Thank you. Very good. Very good.
Thank you. Have a good day.
Bye, everyone.
Thank you.